And welcome to episode 112 of Chairside Live. We got a great episode for you today. My good friend Dr. Malcmacher is going to be back live at the Chairside Live desk. We have a discussion with him. He is going to discuss a couple things with us, the connection between bruxism and obstructive sleep apnea. And then we're going to talk about a little more about Medicare and what this has to do with dentists and why dentists should be paying attention to something that he saw in the ADA news going back a few months ago. Today, it'll be part one where we discuss bruxism and obstructive sleep apnea, the connection between the two, and how we can quantify how much somebody is or is not bruxing, in addition to snoring and having apneic episodes. In our case of the week, we're going to take something that is, I won't call it a greatest hit, but it's a case that we showed, probably about a year ago. We've had several requests to show it again just because it doesn't happen to be on the website. And this is a patient of ours. In fact, he's a technician here at the laboratory, some pretty severe tetracycline staining. We had worked on a relative of his earlier that had tetracycline staining, and we started with veneers, and everything showed through. These dark stump shades showed through. We ended up going to crown. So when it came time to treat this patient, who's also a technician, he said, can we just go right to the crowns and skip all the stuff with the veneers? I think we learned our lesson. And he was absolutely correct. And this time we decided to try it with BruxZir. BruxZir ends up being a material that will block out everything, really. It'll block out metal posts and cores, endodontically treated teeth that have turned very dark, and in this case, a very dark tetracycline case. But as we continue to try to make BruxZir more translucent so that it looks better in the anterior, we're always wondering what's it going to do on these darker stump shades. So today we're going to take a look at that and see, as we make BruxZir more translucent, is it still able to block out something as dark as this patient's tetracycline staining? In fact, let's go ahead and take a look at that now. For this week's case of the week, I've had a couple of requests to pull out one of my greatest hits. I don't know if it's actually a greatest hit, but a lot of people have been asking about what you can put on top of a tetracycline case or an endodontically treated dark stump shade. Apparently dentists have struggled a little bit with some materials that are a little too translucent over these dark shades. So I wanted to share a case with you. It's been a long time since I shared this with you. It's one of the first tetracycline cases we ever treated with BruxZir. But it was kind of for us to see just in fact how much BruxZir could block out. So we found a patient in the laboratory, actually a technician, who had some tetracycline staining. You can see it's pretty good. He's got an edge-to-edge bite too, so that kind of calls for BruxZir if we're going to try to change that and get him away from that end-to-end. But you can actually see the crossbite there on tooth number 6 and 7, and so we know he's a little bit rough on his teeth, but you can see the dark shade he has. I'm not sure why we took a shade there. We could pick any shade that we want. I'm not sure what we thought we were going to try to match by putting that in there. I took the easy shade advanced and put it in too. I just wanted to shoot that shade and see if smoke poured out of the back of it or if it just said C4 plus or something like that. So we anesthetize him. Since we're prepping both these teeth, instead of breaking the contacts as the first step of the reverse preparation technique, I'm actually going to use the 856-025. And I'm going to break the contact and at the same time start the marginal development. And this really isn't a reverse prep video, so we're going to go all Brady Bunch on you and split it into screens and show you just breaking all those contacts at the same time. Oh, here's one of life's simple pleasures. Walks by the lake, frozen yogurt on a summer's day, and cutting off a PFM. Oh, how wonderful that is compared to cutting off some of our new high-strength all-ceramic crowns where it takes 6 burrs in the better part of an hour. So that PFM falls right off. And now we're going to start prepping the gingival margin. This is the 801-021 burr being used on all the teeth really that we're preparing. And just tracing it around at the gingival margin. I'm going to try usually we'd pack a cord at this point, but I'm not sure we're going to impress this case today. We do end up impressing it, so I decided to try it with a different way. Instead of a 2-cord technique, I'm going to end up, when we impress it, putting a double 0 cord in, dropping the margin if I have to, and then using a cordless approach, the new retraction capsule from 3M SB, on top of that. So I'm placing my the incisal edge depth cuts, doing a little slower than I usually would because I'm watching for the color change in the tooth structure just to kind of see it happen. I'm kind of fascinated by it. And now the axial depth cut being placed at the junction of the incisal third and the middle third with the incisal edge depth cut, and we've got our margins already prepped. as you can see highlighted in red in fuchsia, and then in green the incised depth cuts, and in blue, living color, South Park colors, we've got the axial depth cut. And now we take that 856.025 burr and we just start kind of flying through these teeth and reduce until we can't see these depth cuts. Look at that. There's a great look right there at how the enamel's still translucent, and the dentin is where all the tetracycline staining takes place. It's not in the enamel itself. So when we used to try these cases with veneers, the more we prepped into the enamel to try to give us a thicker veneer, the more the color of the dentin showed through. So it was kind of a vicious cycle of prepping into the tooth, going, uh-oh, it's getting darker, I need to have my veneer a little thicker, uh-oh, it's getting really dark now. And we've had patients where we tried that before and it really didn't work. And so crowns have been the way to go, especially in this case, BruxZir crowns to block it out. I can't quite get that Biotemp bridge to fit passively, so I'm putting in the prep stent that the Biotemp technicians used, and I'm trying to find where I haven't reduced enough, and it's usually in the gingival third, and it's usually interproximal somewhere, or it could be on the lingual. But basically with the Biotemps, they've made them so they all draw together like it's going to be a big bridge, but in reality, these restorations are going to be single units. So I don't really need that kind of draw, but I do need it to passively fit. It does passively fit. I'm relining it with bisacryl here. You can't really pump it up and down like you would in the old days with methyl methacrylate, but we want to make sure we don't lock it on. So sometimes as it starts to set, I will wiggle it and then put it back in again. Here's the G5 desensitizer being used. Relic Christensen has shown that 2 1-minute applications of this kills 99.9% of the bacteria. We used to just do it at the crown seat appointment, and one day I asked Rella, why aren't we doing this at the end of the prep appointment before we put on the temporaries, because we know they're going to leak like a sieve and the margins aren't all that great. She goes, no, absolutely, you could definitely do that. And so I thought, wow, that's something we should probably be doing and kind of protecting the teeth before we put them in the temporary. So now anytime we're getting ready to dismiss the patient, whether we're putting on a temporary crown or a permanent crown, we're going to put on those 2 1-minute coats of Gluma, or any of the Gluma-like materials. In this case, it was the G4 from Clinician's Choice, or it could have been Microprime from Danville Engineering. There's all kinds of those that are exactly the same. We lost a little buildup here, so I'm just using some composite to build this back up again, some light cure composite to get an ideal prep. When you work on dental technicians such as this gentleman, they will always look at their models afterwards and want to know why a prep doesn't look perfect. And so you end up making sure that you're able to go in and build up anything that needs to be built up. It's in the best long-term interest of the tooth and the restorations as well. So we're going to put that double zero cord from Ultrapack around all those teeth, and then the retraction capsule from 3MSB around all those teeth, with some anatomic compra caps. Have the patient bite down on it for 8 to 10 minutes, and then go through our steps of rinsing off all that, putting the light body onto the preparations while my assistant loads the tray. Look at that. I'm true to my word with a perforated custom tray for a big case like this, so we get a nice full arch impression. And again, not the same kind of retraction that we get with 2 cords, but enough material underneath it so that it looks really nice. So about a week later, we have the patient back, take the temporaries off. There's the Cavo Sonic Scaler. No better way to clean up a tooth after temporization. I mean, every little bit of temporary cement comes off so you don't have fit issues. We're going to try in the BruxZir crowns. Patient liked what they saw, and so once we've tried them in, we know they've been contaminated with saliva, and as a result, I can rinse them out with air and water like I'm doing here, and they may look fine to me, but I know that the salivary phosphate groups are still bound to the zirconia oxide on the inside of the crown, so I could either sandblast them, or what I'm doing in this case, because I'm too lazy to walk down the hall to sandblast them, is use some IvoClean from Ivoclar, and this 12 to 15% zirconia oxide solution, and I'm just getting it, spreading it around the inside of all those crowns, and this is going to remove all those salivary phosphates from the inside of the crown and allow us to put these crowns in without worrying about it. So if in fact we're going to put these in with a resin cement, we would place Z Prime Plus and then a resin cement, but we're not. We're using Ceramer from DoXA, and this is a calcium aluminate glass ionomer cement. Then we're going to triturate it here. This is a very hydrophilic cement, just like the zirconia oxide. The BruxZir material is very hydrophilic. If we put Z Prime Plus on the inside of this crown, it would actually not work because the Ceramer cement needs to be in contact with the zirconia oxide. In fact, the Ceramer cement really doesn't even care about the the contamination. So I could have put these crowns in without going through that IvaClean step, but once you learn that you've got salivary phosphates there, even though Ceramer doesn't bond through that same mechanism, I just like knowing that the inside of the crowns are quote unquote clean, even though that's not really how we mean contaminated. So we're going to go ahead and place all those in, and through the magic of morphing software, you can see that we go from the tetracycline befores to the BruxZir afters. And is that the most aesthetic set of crowns you've ever seen? Not likely. But when you look at that, look at what a huge improvement that is for him. And it's going to be a little bit before we get to his lower anteriors, because we have a few other patients who are dying to get in and kind of have this treatment done too. And as we start to play and experiment with our more translucent BruxZir material, we want to make sure that we're still able to hide some of these dark stains. So you can see his smile on the left and the relaxed nature of the smile on his right. His face just kind of lights up a little more. The smile looks more natural. His eyes look a little bit different. It reminds me of that woman Dr. Malcmacher showed who, once she actually had the Botox and stopped clenching so hard and her masseters went down, it changed the way she looked. And for this technician that works here, the BruxZir crowns changed the way he looked. Hi, I'm Dr. Michael DiTolla, the Director of Clinical Education here at Glidewell Laboratories, and part of our ongoing Chairside Live clinician interview series. Dr. Louis Malcmacher is here again. Louis, nice to see you.
How you doing there, Mike?
I feel privileged that I get to see you again, and I know that with your schedule and your teaching schedule, you're out in Los Angeles for almost a week or so every 6 weeks, something like that. Is that correct?
We are out here a lot because there are a lot of California dentists. A lot of things that we teach are they're interested in a lot of it. So we're out here all the time giving courses up and down the state of California and throughout North America practically. So we're all over the place.
The last numbers I saw, I think, for and it's been a while, for dentists in California, it was like 17,800. Is that, do you know if that's any different?
I think it's around, I think it's pushing 30,000 or something.
Is it
like
really?
That
was many years ago.
Quite
so
a bit.
30,000.
From what the dental board says, I think they license about 30,000 dentists. And then, 10,000 or more than that hygienists. There are a lot of people out in this great state of California.
Right, and we're here in Newport Beach, and then literally like 4 or 5 blocks away from us is Allergan, the manufacturer of Botox. I'm guessing that you're one of their biggest dental client, I might say?
We're one of their biggest clients, in general, because
really?
We do a lot of teaching with that, and we get a lot of new injectors, people that do facial injectables, including dentists, but we've got a lot of physicians and nurses as well. So yeah, they're close by. It's great to come visit you because then I get to visit them as well.
So most of their, I guess, customers are just single, say, plastic surgeons using it, but you, because of all these courses, are ordering way more than they are.
Yeah. I mean, we use a lot in our own practices because we've got a number of practices as well. But we're getting a lot of dentists into this whole area of facial injectables, as you know, and as we've talked about before.
Right, and that's fantastic. I'm glad that you're out there doing it. I'm glad that you're here in California on a regular basis. That'll allow you to come by when time allows, when you're not either teaching, shopping at Rodeo Drive, eating at Scarpetta, Bouchon Bistro, or several other restaurants that I'll try to force you to take me to for dinner. And today I wanted to talk about something that I know you're interested in. I made a clinical DVD with Gordon Christensen probably about 6 months ago on snoring and sleep apnea. And when we got involved with that, we met a guy, Jeff Weiscarver, who has a at-home sleep testing device. And one of the interesting things about it was that it also measures bruxism. Jeff pointed out to me, which I didn't know, that most sleep centers, when you actually go to a sleep center, they will often measure bruxism, but they don't know what to do with it. So they don't send it to the medical doctor as part of the analysis, and it never gets to the dentist. I know that you are very interested in bruxism, and Gordon recently made a bruxism video, and he brought Jeff in there because of that monitor as well. So I'd love to hear your take on this, if you've had an opportunity to use this device, and just overall your take on bruxism and how it relates with sleep apnea and some of these other
sure.
things.
We use that device a lot, and now, Jeff Weiscarver was looking for a dental distributor, and the dental distributor by the name of StatDDS stepped up, and they're the ones who really have taken the whole thing by storm. And the way we looked at it is like this, and we really liked it a lot because there are a lot of different sleep testing devices on the market.
Right.
Now, the question is for a dental professional, because they can't diagnose obstructive sleep apnea, no matter how much data they have, the way into that really to really work with a physician is by measuring bruxism. And that monitor, and now it's been renamed the StatDDS Bruxism and Sleep Test Monitor, that monitor has now been key in tying those two things together. Plus the fact that, when you talk about bruxism therapy, it is one of the most common dental diseases, and it is a disease. It's so common to the dentists and dental offices, we don't even think about it. Like, okay, a patient's got bruxism, here's an appliance, right? And it's one of the biggest things that we don't measure, and you can't treat what you don't measure. I mean, imagine trying to treat periodontal disease if you have no measurements, right? If you have no diagnostics or anything like that. So finally, and that's the special thing about this StatDDS monitor now, is that it can measure this. And like you mentioned, sleep centers actually measure some of the muscles that cause bruxism, but they really don't have the software and the acquisition to go ahead and give a dentist any kind of reasonable numbers. And that is, part of, what DDME in conjunction with StatDDS has done, because now I can take a home sleep test, but it's also a bruxism monitor test, and get data on bruxism. Now I'm the primary provider on that. I call a physician and say, hey, I tested this patient for bruxism. Here's the numbers, and the number is 5 and above when it comes to a bruxism episodes index. Go to the physician and say, I also have some data that might interest you on obstructive sleep apnea. Now the physician is willing to go ahead and talk to me. In the past, what would happen is a lot of dentists, were trained by different organizations to use a standard sleep test, and some of those are pretty outdated. They don't use them in sleep labs or anything else. It's like dentists are the only ones using some of these sleep monitors that are, that no medical, physician is going to touch anymore, which is a kind of a strange thing in dentistry.
And when dentists got involved too, they would often get intimidated about contacting a medical professional, a board-certified sleep specialist, because they felt like the sleep specialist knew so much more about this than they did, and it was kind of embarrassing almost to go to them. I like your approach, because now a dentist who knows more about bruxism, having observed it for 20 years, gets to contact a medical professional on a topic of something that they know a lot about. And oh, by the way, here's some sleep numbers. And so it's a little different. Instead of being like this, it's kind of like I'm coming to you telling you about this bruxism, and I'm giving you this obstructive sleep apnea information. Can you help me work with it? And I like your, if it doesn't get measured, it can't get treated. It would be like trying to, if the perioprobe hadn't been invented and you were trying to treat periodontal disease, how would you ever determine if it was mild, moderate, or severe if you couldn't go in and actually measure the pockets? Right,
it's the same thing, endo. Imagine treating an endo, without having
like that. Mine look like I haven't used a ruler.
We've all done that, I guess. But
well, I feel bad.
To do it.
I feel bad telling the patient. I show him the X-ray and I go, now to make sure you never lose this tooth, I've put the gutta percha 5 millimeters out the apex to help anchor it into the bone.
Absolutely.
And they go, oh, thank you. Is that extra? No, I include that for free. Don't worry about it.
So here you have bruxism, which is the most common dental disease, and we've never measured it because we've really never had a way to measure it. And the conversation with the physician is, patient has bruxism. I also see that they have some numbers you'll be interested in terms of obstructive sleep apnea. I can make an oral appliance that will go ahead and take care of both. And the physicians, when they hear that, say, it's yours. Go ahead and do that. In the past, they'd only get sleep numbers, the AHI, the apnea-hypopnea index, and say, great, thanks very much. I'm sending it, to my sleep lab or my friend's a pulmonologist. And dentists always get this from patients too. Why are you talking to me about sleep? Like, can you diagnose it? No. Are you the physician? No. Well, then why am I here? But if I'm talking to the patient about bruxism, and they also have some sleep apnea issues, then it's a whole different conversation. And the truth of the matter is, a lot of dentists have gone ahead with this monitor just for the bruxism. They may not need or want to know anything about sleep. I think they should, because you can literally save people's lives. But if they just want to measure bruxism, it'll change the way they think. It'll change the way they determine, does the patient need an appliance or reconstruction, et cetera. And I can measure the results afterwards.
And we're no longer having to ask a patient, do you grind your teeth at night? No, I don't. Well, obviously they do. So you change it to, are you aware you grind your teeth at night? And now it's a little different question because they can't really deny it. You're just asking them, are you aware that you do it? And if their spouse sleeps heavily, they won't know. At least this is proof. And I was at the AAED meeting, the original kind of multidisciplinary group last month in Santa Barbara, California. And 2 times on the first day, while they were doing these interdisciplinary full mouth reconstructions on people with severe wear and attrition, it came up to hear the clinicians say, and it turns out that the patient also has obstructive sleep apnea. And we know now from devices like Jeff's that the whole clenching and grinding of the teeth is part of the response to wake somebody up in the middle when they're starting to suffocate in the middle of an apnea episode. And it was interesting to hear the old school AAED really kind of talk about this, and it's becoming clear that dentistry is starting to recognize that bruxism and obstructive sleep apnea are intricately related, and that we might, by us seeing these bruxism signs, yes, we can help somebody save their teeth, but we're knocking on the door of something bigger, and we might be able to save a life in addition to just saving these teeth.
But even with what you just talked about in terms of reconstruction, how in the world do you do a reconstruction without getting the patient's bruxism under control? Well, if I fix the occlusion, that'll get the patient's bruxism under control. We know that's not true already, and that's where we've added Botox to the whole mix to weaken some of the muscles and to really take care of bruxism, and now we can measure it, and now we can prove it. But if I see someone with a high bruxism episodes index, I've got to address that first before I start doing a lot of crowns. I tell every bruxer the same. I've told them this for years. You know, you've already destroyed the best thing we have in dentistry, and that's called teeth. You know, I can't do better than God. I can't make teeth better than God. Okay, you've destroyed that. You'll destroy my crowns, my implants, just about anything else I put in your mouth, unless we get your bruxism under control. Now, if the bruxism comes from obstructive sleep apnea, unless I get that under control, I can't get the bruxism under control. Or if I'm using something to really address the muscles to calm them down, and that's where Botox and all that comes in after a few years now that we've really been doing this and measuring this. A whole different scenario. I would never put implants into a patient now without doing it. And we test everybody. I mean, it's less than $20 to test. Our model in our practice is test everybody. I'll swallow the $20. We're making more bruxism appliances than ever. We're making more obstructive sleep apnea appliances than ever. It's very profitable. You do better dentistry because I don't do a full mouth reconstruction until I take care of the bruxism, and you can save someone's life. That's a great combination, and really that's the best kind of outcome you can hope for.
You went down a different path that I thought you were going to go when you said you say to the patient, you've already ground through the best thing available, God's crowns. There's only one other thing I can give you that's a little better, and that's Jim Glidewell's BruxZir crowns.
Absolutely.
But that's not where you went. You went a totally different direction.
Sorry.
No, that's fine.
Because I've been using that line for so long. We didn't have BruxZir when we started.
I'm not going to say BruxZir's better than what God does than natural teeth. I'm starting to sound like John Lennon or whatever Beatle made that really controversial
It's starting to sound like Jim Glidewell's God. So,
exactly, and I don't want to say that even though he knows he is. So I have to say that because we're on his set as we film this. But yes, you want to get that absolutely under control before you go in there and start to do it. And it's interesting because there was a position paper from the Medical Sleep Association years ago saying that for mild to moderate obstructive sleep apnea, that oral appliances were a great first-line therapy. Not for the severe people. We want to get them on CPAP because it's still the gold standard of OSA. But it's interesting now, the way you're approaching it, that if it is a mild or moderate AHI and somebody who is mild or moderate obstructive sleep apnea, that we can now provide them with something that, yes, treats the sleep and stops the bruxism, because the CPAP's not going to stop anybody from bruxing their teeth or protect the teeth directly. But if it does treat the apnea successfully, they should stop clenching and grinding their teeth. So what does all of this have to do with Botox? Does this tie into Botox at any point, what you're doing with this?
Yeah, well, these are all different modalities. I mean, they're all different modalities. And also, I just want to say one thing to make sure, because, you know, we'll get some of the hard heads in dentistry that are going to yell at us. There's bruxism on its own, and there's bruxism associated with obstructive sleep apnea.
Correct.
Not all bruxism comes from obstructive sleep apnea, and that's the great thing about this monitor, because you can do it just for the bruxism, but again, you can't treat it if you can't measure it. And Botox comes along and helps. You know, we've got to get out of this notion and finally put a hatchet job to this whole thing of bruxism is because the occlusion is wrong. Occlusal equilibration will fix it. The TM joint has to be in a certain position. That's not how people are built. We know that after many years in dentistry at this point in time already. So let's take out the muscles are the ones that are given the strength behind that bruxism. Let's take them down a notch, and the way to do that is botulinum toxin, Botox, because that will go ahead and weaken the muscle. And again, you need to get trained in this because you don't want to put those masseter and temporalis muscles to sleep, or the patient walks around like, all right, this all the time. They have no competence, they can't chew. But if you can just take this kind of grinding that's causing this bruxism down to half strength, then you've gotten rid of a lot of oral facial pain, a lot of the destruction on teeth, and it's a simple injection that you need to be trained to go ahead and do by every state dental board and everybody else in the world. I mean, you need to know what you're doing because these are very strong pharmaceuticals, but when you use them, they're great. And now we've got lots of cases, which I can show you one of them, where we can actually measure that with this bruxism and sleep monitor and exactly measure, what have we accomplished? And that's great for me because I give someone Botox,
Absolutely.
I measure them afterwards. Do they need a little more? This is fine. They're doing great. It's
yeah, kind of like you said before, you probably never really had a way to measure it before. And I was surprised when we started using it on some of the employees here. We would see bruxism, but no OSA on somebody who said, "Oh, my wife says I snore all the time." Well, you snore a little bit, but you don't even rank on the AHI. But look what you do. You've got all this activity with your teeth. And then we saw people who thought they were grinding their teeth, who really weren't bad, but did have more of an apneic component to it. So it's great to be able to do this at home. We had a new employee here last week at lunch who was describing to us a sleep study that he did 2 years ago at a sleep lab. And it sounds so crazy to try to have wires attached all over your body, get into a strange bed that's not yours. There's a guy with weird facial hair looking through a little window at you. Although actually he said there was no window, there was just a camera pointed at him that would move back and forth as he moved back and forth. And in the middle of the night he had to go to the bathroom, so the guy came in and unplugged all the wires so he could go to the bathroom. And he said it really was probably the least restful night he's ever had. So I love the idea of being able to do this at home because I think we get away from all the stress of sleeping in a strange bed with rubber sheets, while somebody else watches what you're doing in case the leads get unattached. And I love the idea of doing it at home. Show me what you got. I'd love to see this case.
Let's take a look at this here. Okay, let's take a look at this case. This case is a perfect example of what we're talking about. Now, you just look at this patient and you can see from just how big her masseter muscles are that, this is a long-time oral facial pain patient. She's had every kind of bruxism appliance possible. She's had all kinds of medications she's taken for the oral facial pain. But again, if you're trained in Botox, you can just see how big her masseter muscles are.
And I'm not trained in Botox, but even sitting here, I'm looking at this left-hand side, and I recognize this look. I used to see it on my dad when he was really angry at me. So I'd see this bulge, and I'd see the temporalis bulge up here, and I knew to turn and run.
But this is her at rest. I mean,
this is her resting.
Yeah, she's not biting her teeth. This is her at rest. So, this is a masseter that is way out of control here a little bit. So we measured her, and here's her first, and you see I got the question on top, can Botox cure bruxism here? Here are her two numbers. You can see the big AHI number down here, and that's 4.8. So 5 is the number that, would give her a clinical, data that she's probably got OSA, obstructive sleep apnea. So she's right underneath that here, but 2 lines above it, the bruxism episodes index, same thing. 5 and above is clinically significant destructive bruxism, and she's at a 5.2, which is a number, I've seen higher numbers, I've seen lower numbers for that. So, but 5.2, she certainly got it, and just by looking at her masseter muscles, you know what's going on there. So then we go ahead and we give her some Botox in those masseter and temporalis muscles, but this measures specifically the masseter muscle here, and you can see her AHI, interestingly enough, the obstructive sleep apnea number has also come down, and that's, we don't know the mechanism for that just yet, but we are testing that in the AAFE through a big research project. But to look at 2 lines above it, her bruxism episodes index, 0.6, so it's completely disappeared.
And how long was this second test done after the administration
Second
of Botox?
test was about 2 weeks after the administration of Botox. And it usually takes anywhere from 2 to 10 days for Botox to kick in anyway into the muscles, but this is 2 weeks later. So we've pretty much eliminated her bruxism with Botox, and now we can prove it. And we've seen this in patient after patient, and that's why I have at the top of this slide Botox is a better alternative. It may be a better alternative than a Bruxism appliance.
Well, certainly the compliance is higher.
Right.
You don't have to remember to put in your Botox every night before you go to sleep.
That's
and you don't
exactly
get claustrophobic with a big chunk of Botox sitting on your upper teeth as you try to fall asleep.
Absolutely. I'm not getting rid of Bruxism appliances.
No,
Lots of reasons for Bruxism
understand,
appliances. But there's no compliance issues. Patients, by the way, their massages get smoothed down, so they love that effect.
Right.
But they have full competence in eating and everything else. But now I can go ahead and measure it and really see the outcome. Now, if that number's a little higher, she's still got some pain, give her a little bit more, it can come down. In her case, took care of it. But this is her before picture again that I just wanted to show you. And now, take a look at her face afterwards. And I mean, it literally looks like a different person.
Wow.
It's the combination of taking care of facial pain and giving a patient great facial aesthetics and also going ahead and eliminating their bruxism with this. Now, if she had obstructive sleep apnea, we may give her Botox in conjunction with an oral appliance for that. That's a big difference. And she loves it.
It's night and day.
Yeah, she loves it.
Here it looks, did you drag her out of her bed in the middle of the night and take this? It looks like she was kidnapped. And this is
like
the shot sent to the family with the ransom note. And then afterwards, I mean, look at her there. She's gorgeous.
Yeah.
I I understand she has makeup on, but you're right. There's just a different kind of relaxed look. Her face no longer has that type of wide flared mandible look. It's just kind of round and oval.
Right.
And,
like she's clenching. You thought she was clenching in the one before.
I did.
No, that was a rest. That's a big difference.
I don't do this kind of treatment, so after you give her the Botox, 2 weeks later you give her that second test to verify that if she filled out a survey like the night before or the night after that, what does she say? Does she notice any difference with I'm not waking up sore? I mean, is this something that's aware to them?
Absolutely. Because she can't physically brux because we've taken the muscles and we've gone ahead and they don't contract as solidly and as hard.
But she can still chew food. She doesn't have to have someone chew her
full
food.
competence. No. Doesn't have to eat baby food. Doesn't have to share her food and have someone else chew it.
Like a baby bird, have her mother chew it and spit it into her mouth.
No, that's the trick. And that comes with good training and understanding dosages and how to use, Botox. I mean,
but you could, if you didn't know what you were doing, you could actually.
Oh yeah, you could give way too much Botox. Their whole face starts to fall. They don't look good. I mean, that's the danger with it. When it comes to for anybody that's listening that has not been trained in Botox, when it comes to pharmaceuticals like Botox, less is always more. I can always go back and give more.
Right.
But once it's in there, I cannot take it out. So the trick is, and this is something that we, by the way, have a lot of neurologists come to because Botox is used for chronic migraines. The problem is they give all this Botox as a neurologist, and patients face literally they can't barely open their eyes. They fall because they've taken out all the activity of all the muscles. That's the trick, is how to get good at the combination of taking care of facial pain, headaches, migraines, TMJ, all those things, and balancing with great facial aesthetics where the patient has no pain but still looks great. And that's something, and that's the bulk of what we teach.
Next year we're going to introduce what we're calling in-house anterior BruxZir. It's a much more translucent version of BruxZir than you've seen before. In fact, it can rival some of the other very aesthetic anterior high-strength all-ceramic crowns that we are currently using. And this is going to be one of the interesting patients to see whether or not it'll still block out that shade. So this patient and I have a deal. As soon as we are ready to launch the new anterior BruxZir, he's going to come in and I'm going to cut off all 10 of those crowns. I'll film that and let you watch that as well. We'll see if I can get that done in less than an hour and less than 50 burrs when we go and do that. But we'll place the new BruxZir onto him and make sure that it can still block out the type of tetracycline staining he has while being translucent enough to really be considered an anterior aesthetic crown. So that about wraps it up for this edition of Chairside Live. On behalf of myself, the CSL crew, and everybody here at the lab, I want to thank you for your time and your continued commitment to quality dentistry. Hey now, hello and welcome to episode 112 of 112. Sounds like an apartment number. Did you drag her out of her bed in the middle of the night and take this? It looks like she was kidnapped. And this is the shot sent to the family with the ransom note.